All Saints, Pure Shores, 8:16 on your Thursday morning.
It is a Thursday.
It is
Indeed.
a Thursday.
Getting it right all the time.
Not
FD,
bad this week, huh?
The date man.
I'm getting there.
Man.
I'm getting there.
Hey.
All
I'm
right.
proud of you.
Oh,
Yeah.
thanks.
Just want to say.
Thank you.
Okay.
Oh.
Moving on to the most important thing
Yes.
on the show on Thursdays
Yes.
is our amazing segment, I Wish I Knew, with our principal therapist, Liz Piper from Lifeweavers Therapy. Episode 6 already, my goodness.
It's crazy.
When you are facing, you're having a good time and also discussing all these important issues, right? The episodes just fly past. We're now at episode 6, and it is a good one today.
It is.
Yes.
How a simple UTI can trigger delirium in older adults, causing memory lapses,
Yeah.
personality changes,
What?
and alarming behavior shifts that are often mistaken for dementia.
I hope this is not too much information, okay? Not a TMI confession, but I have had UTI before, right? And I'm
okay.
like, did any of this happen to me? I must ask my loved ones.
You've got to check with your
right?
husband. Yeah.
I was like, did I?
All I know is now if my wife forgets anything, I'm going to go get checked, baby. You might have a UTI.
or something.
I am not
else.
responsible.
No, you're not. Yeah. No, you're not. But you just gave me the best line. Welcome, Liz. Thanks for joining us again. Okay.
So let's get started.
Let's get down to this. Dementia and UTIs. Why have you put them together in the guide? What is the link?
So basically, UTIs can speed up cognitive decline in people with dementia.
Is it a
Right.
temporary thing or?
So for people with dementia, it can be permanent.
No,
Yes. So normally
that's
when you have a UTI, if you present with symptoms such as confusion, which can happen,
Yep.
and
Good Lord.
FD's wife, this is not on me.
No,
okay?
don't worry. No, we were just kidding. We were just
What you
kidding.
started
And
for
yeah,
yourself.
so but once the UTI is cleared, you take your antibiotics, then everything goes back to normal, confusion
Right.
clears, you become clear again. But trends show that people with dementia don't always return back to how they were before the UTI. Okay, so symptoms like increased confusion can stay, which basically accelerates the person's decline overall. Now, if they've had one UTI, the likelihood is that they're at risk of others. So if you're having
Really?
sort of recurrent infections, it is speeding up this rate of decline, and also, which in
gosh.
dementia can increase the amount of symptoms you're managing as a caregiver or as the person with dementia. Also, people with dementia are much more likely to need hospitalization
Okay.
as a result of that. And, being in bed for a few days results in becoming frail. Remember, we talked
Yeah, we
about
did,
Yep.
yes.
if you're
Yes.
lying in bed for 3 days, you start having muscle loss, then
Yeah.
that increases frailty and falls risk. So there you get this cascading amount of issues. And I think why we really wanted to put this in the guide is
Yep.
because the
Yep.
signs are easy to miss in people with dementia.
I see.
Because
So-
they're so similar to what dementia actually is.
symptoms
Exactly.
of, like,
That's
okay.
exactly it. So if you're
Okay.
already showing some challenging behaviours,
Yeah.
there's lots of debate on what the politically correct
Yeah.
way is to explain that. But when people are already showing behaviours that wouldn't be their normal before dementia, it might be more difficult to pick up because they might become more relaxed, in which case the caregiver's like, oh, it's a good day.
Yeah.
Or they might become more argumentative. And if you're a caregiver who's already thinking about 100 things at 100 miles per hour,
Yeah.
it can
Yeah.
also be difficult to pick up on those subtle
You can
differences.
easily miss it. Yeah.
So when you pick up on things sooner, as we've discussed in the
Over
other
the weeks, yeah.
episodes, it's easier to recover. It's easier to sort of bounce back from there, or bounce back as much as you can.
Yeah.
When things are left longer, that's when things become more difficult. But again, many caregivers are stretched and stressed. So picking up on these signs, aren't always, thinking of a UTI won't be the first thing that comes to their head.
Yeah, it won't be. True.
So it's really about, again, when we've been in to see clients before, and there is a difference between if we're already seeing a client and we're seeing them regularly, we can pick up quite early on.
Right.
Looks like your mum's showing a change.
Yeah.
And I've even done things as crazy as saying, can I sniff her diaper? because you can actually smell a UTI on a lot of people.
Sorry?
Right.
It does smell different.
Oh, we gotta
Whoa,
jump in.
yeah, we gotta do
into
this.
that. I need to know about this. So yes, this is all part of their brochure. I Wish I Knew. You can download it at iwishiknew.lifeweavers.org. Let's hop onto Facebook right now.
What a way to end on the on the air.
You can smell
yeah.
a UTI?
Yeah,
Or-
so if you've worked in a hospital long enough and you've been around lots of UTIs, you just are able to.
What is that scent?
There is a smell. It just means the urine's much more pungent, much more smelly, basically. Yeah, got a much more smelly smell to it. This is not a fail-safe test for
No,
UTI.
obviously.
Yeah,
Of
testing
course.
for you, but
Obviously.
it does sort of give you a good indication. So if I were to pick up on a smell like that with someone, I would be sort of really how to say it nicely, but much more encouraging for them to go either to the GP or directly to the hospital. And there have been cases
Right.
before where I've helped ring the ambulance for my patients and helped them go to the hospital, and they have had UTIs and
Yeah,
and
because
been in for a
UTIs
couple
can
of weeks.
graduate into a possible
Wow.
kidney infection.
Go to
as,
kid-
you know.
we'll first go to bladder and then go
Yep.
to kidneys,
Kidneys,
if
yeah.
it's
So,
untreated.
you know, it is
Absolutely.
quite scary.
Yeah.
Absolutely.
And just the rate at how it can progress is also quite
Absolutely.
alarming. Yeah.
So, I mean, of course, prevention is best. If you even thinking about those risk factors that would happen before the UTI,
Yep.
things like, is the person drinking enough?
Yep.
Because when we drink, we pass urine. When
Yes.
we pass urine, the bacteria is being flushed
Yes.
out.
Yes.
When
yes.
we're going to the toilet less, the bacteria has more chance to climb up again.
Ooh.
Things like staying in diapers, like wet diapers for a long
Yeah, you
time.
shouldn't, yeah.
This can happen if caregivers are very stretched.
Yep.
And then also, if a person is managing their personal care independently,
Yeah.
keeping an eye on how they're managing their personal hygiene downstairs.
Yeah.
Because if they're passing motion and they're not doing a very good job of cleaning themselves up, this
Yep.
can obviously turn into
Yeah, yeah.
infection and things like this.
Okay.
So that would be the sort of prevention side of things. But also, a lot of UTIs happen for reasons that are unknown to man at the moment. So if you are a caregiver and your loved one has had a UTI, definitely don't beat yourself up about it. Most women will experience a UTI in their life,
Yeah.
at any sort of,
I'll
age.
admit it. I got it.
Yeah, so most of us do know what that feeling feels like as well. So ideally prevention. If not, let's try and educate people to pick up those signs early and what to do about it.
And
So-
in order to do so, pick up this brochure.
Yeah, the
Okay?
brochure is very,
This
very
brochure is not the actual brochure. This one here that I have in my hand has, more importantly, this QR code. But you can actually download the full brochure, and it talks about why you've included what we're discussing today in it. You can find it over at iwishiknew.lifeweavers.org. Okay, iwishiknew.lifeweavers.org. It's a free guide to help you understand a lot of things that you should know.
And speaking of the guide, in the guide, you've divided the red flags into two parts: diagnosed dementia and undiagnosed dementia.
Yeah.
So for anyone, caregiver or family member or whatever, what are the things that we're looking out for?
Yeah, so for the undiagnosed dementia, you're looking for sort of a bit more general things using a basis of a person who's not needing help with their day-to-day living. Yeah. So there can be people that have the beginning stages of dementia, but they're still holding their own and they're using their own compensatory strategies, or they're sort of like masking the problems that they're having. So in these people, you'd be looking at things like slower thinking speed, more forgetfulness. They might be getting lost. Might be finding it they're taking longer to get home from the shops, becoming withdrawn because they're sort of not entirely sure what's going on and might be a little bit too shy to sort of express to people that I'm having problems. So they will withdraw. Minor physical changes like feeling weak, loss of concentration on things like feeding, so you might be coughing more when they're feeding because they're not focusing so much on the swallowing, bumping into objects.
Wow.
And then another a big one is not sleeping well at night. So there could be a switch where they're awake more at night and then sleeping more in the day. And this is actually quite a classic dementia symptom as well, where their sort of body
Really?
clock starts to switch and go the wrong way
wow.
round. Or they
Oh.
have something called sundowning, which is where there seems to be a burst of intense behaviour. It can be very happy or very aggressive. And for the hours basically as the sun is going down as well. So that
Wow,
can
okay.
turn to a pattern. But for diagnosed dementia, you would be looking at you'd be using their current mental state as a baseline. So in terms of their pre-existing deficits and seeing a unusually fast acceleration of those.
Okay.
Yeah. So actually, for anybody with dementia, if you're noticing a sort of faster acceleration on symptoms, whether it's confusion, becoming more aggressive, or starting to do very unusual, strange things, that is really a case to go to the doctor, because UTI is one thing, but the other thing, because dementia is an umbrella term,
Yeah, it
there's
is.
lots of different conditions under
Yep.
the umbrella of
Yes.
dementia.
Yep.
You know, it could be things like little strokes as well. You know, you could be having other things going on. So really, if you're noticing behaviour changes, better safe than sorry, go to the doctor or go to the
Okay.
hospital.
All right,
Wow.
we're going to go back on air, and I want to talk about how we find out if it's UTI or not.
Okay.
Alrighty, Patrice Russian, Forget Me Not. Oh, I remember that from my very early days.
Oh,
That's a beautiful song.
good.
8:27. So let's get back to this. So if you see the changes you've just mentioned, how do we find out if it's a UTI or not? Is it immediately go see a physician, or what do we do?
Yes, go and see a physician. That's basically what you need to do. So don't need to think too much about it. If the person's mobility or function has been affected to the point where it's difficult to get them in a cab or a car, then calling an ambulance is absolutely fine.
Yep.
That's okay, because
Okay,
this would be
okay.
considered emergency. If it's left too long, obviously it gets worse, and then
Yeah.
that can
And a whole
impact the
host of other
person's
problems.
organs and
Yeah.
all that sort of stuff.
Oh.
I know that sounds really scary, and I could be accused of scaremongering here, but it is true, and I'd rather know that early on
Yeah.
than
Yeah.
find out
Stop
later
it, early
and
on
say,
in
I
its
wish I
tracks.
knew.
Yeah.
So it's going to the doctor, and what they would do is they'll either do a blood test or a urine test,
Yep.
and they'll be able to find out from that.
Yep.
Super quick, super easy. And if they're not picking up a urine tract infection from that, then they're going to know that they need to dig a little bit deeper and see if there is anything else going
Right.
on.
Sure.
So yeah, anything out of the ordinary, accelerated change in function or thinking, being really drowsy or suddenly being much more awake than normal. These are all kind of the red flags you need to be acting on.
Okay.
It's interesting because, this is just an announcement for people.
Yep.
So many of us these days, we see little symptoms or things happening in our life, and we go to Google and what does this mean? And I think what we're learning in this instance is, see the symptoms, you don't need Google, go to the doctor.
Yeah, because these symptoms will also be based on you.
Yeah.
So if you were somebody who had difficulty, you mentioned earlier about remembering the day,
Yeah.
who had difficulty remembering the day or remembering the week, and you typed into Google, not knowing what day, week or year it is,
Yeah.
Google will of course give you a whole host of problems that you could potentially have.
Yeah.
But if you know you've got dementia and that's where you're at with
Yeah,
your dementia,
yeah.
then that's not your red flag. Your red flag could be lying on the bed thinking that you're riding a bicycle whilst people are coming out of the sky or whatever. And that's an example, a real example of a lady that I saw.
No.
So those are
Gosh.
the sort of changes that you'd be looking at.
Wow.
And I think the other thing is that, people try to live with these, the pain or the symptoms
Yeah,
itself.
totally.
And then it just gets worse. So I think the key thing here is when something is not right, it's unusual, like it's out of the ordinary, check on it.
Yep.
Right? Whether you go to a GP or whether you go to the hospital, check on it.
The interesting thing is, and this is before you came in, we were reading this, and we went, rehab for dementia,
Yeah.
rehab
Yeah.
for a UTI.
Yeah.
Neither of us had ever heard of that before.
Yeah.
Oh, interesting.
So
Yeah.
what is the role of the rehab therapist
Yeah,
in
the-
all of this?
Yeah, the role is really enormous because you've
For
got your
sure.
diagnosis of
Yeah.
dementia, and that's that. You might have some medications. But then the rest is about how you're coping and managing with the condition in your day-to-day life. So we'll split it into two parts. We'll look at dementia on its own first, without the UTI. So with dementia, the goal of the rehab therapists is to delay symptom advancement. So we know there's no cure for dementia at the moment. They're doing loads of work on it. We want to prolong independent living through cognitive and physical activities, because depending on where the dementia is affecting the brain will depend on what your symptoms are. So if it's more at the front of the brain, you'll be having more issues perhaps with inhibition, emotional regulation, personality. But if it's in other parts of the brain, more towards the motor side, you might be struggling more with motor, and memory tends to be affected in most people. And then, really importantly, is doing training for the caregivers to help give them the skills to support that person better. So really, putting it simply, is how can we minimize all the arguments and frustration between the two people?
Oh, wow.
Right.
No, that's very significant.
In a way that empowers the person with independence, but also cares for the caregiver. Yeah.
We're actually going to jump onto our Facebook Live to carry on this discussion, because, that's the thing that I find very intriguing. When patients with dementia, they can't quite control everything that's happening, right? So how do you carry out, the rehab therapy on such an individual? Yeah. So let's talk more about that.
FD.
Yeah, so I find, I think that's why we never really thought is the rehab therapy, done on the patient who's or the sufferer of dementia, because the decline is happening. It might be beyond what they can control or even comprehend. But I guess it makes sense, because you pointed out on air that the rehab therapy also works with the caregivers. Now I can see, because they will eventually have to take on the full responsibility of caring for that person. But you said that no, it's also important because it minimizes the arguments as, I guess, the personality change is happening with the individual with dementia. So can you tell us more about that, again, about rehab therapy and other ways that it can come into play and help the situation?
So what we do when we see a person, first of all, is we want to kind of separate the types of decline. So there are going to be two types of decline for most people, which we generally see, not for everybody. But there's a decline due to physical changes in the brain due to dementia. So those things we can't treat.
Okay.
And there's a decline because as a person's been struggling with their brain damage, essentially, they're doing less. So because they're doing less, they're losing function based on, basically, if you don't use it, you lose it.
Lose it, yeah.
Sure.
So there are skills that don't seem to be there, but they're actually just dormant. Yeah, it's actually where the brain's just gone, oh, well, I haven't needed to do that for a while, so I'll just switch off that thing. So what we'll be looking at initially is what things are dormant but still work. We want to get those back.
Give us an example of these things that could possibly go dormant, and then trying to draw that back.
Yeah, so I think something, oh gosh.
Would it be like using, I don't know, using a fork and no?
Using a
No, I think
fork
it would
and
be more
spoon,
things it
more.
could be something like, okay, really good example actually is loved ones being very caring, saying, Grandma, don't worry about doing the washing. Don't you go and do the marketing, because, we want to look after you and care for you.
Sure.
And so she ends up doing, not doing her normal routine of going out into the community and using the washing machine and doing all those things. So what does that impact? Well, that impacts her functionally, because if you're lifting wet clothes out the washing machine and hanging them up, that's a bit of a workout actually.
Yep.
So, and then walking to the shops every day, that's also a bit of a workout.
Yes.
So you're losing that part. So in terms of balance, muscular strength and all of that. And then also in terms of her routine, how she orientates herself to the day. So before, if she would get up, put the washing on, put the washing up, she knows that's morning. And then she goes to the shop before lunch and she knows that's lunch. And after I go to the shops, I eat. So if you take the shops away, she might be losing her lunchtime.
You're taking elements out of the system.
Yeah.
That they have to The system they use to go through the day.
Yes,
It's like a muscle memory sort of thing, and
exactly.
And
So
if-
routine.
And
Wow.
you're removing things from it.
Wow, I never thought of it that way, you know.
Yeah.
I think caregivers would be like, oh, we want to really just assist you,
Yeah.
help you, don't want you to get
Yes.
hurt,
Yeah.
you know.
And
Wow.
for people with dementia, because the short-term memory system tends to be more damaged, what we try and leverage on more is the long-term memories.
yes,
So if
yes,
somebody
yes.
was a housewife, or if they had a particular work routine, we would want to understand that. What was your routine 20, 30, 40 years ago? Because if you're kind of a little bit more living in the past now, we want to be leveraging on that routine to build your current routine, basically, in a way that makes sense to you, that you can remember,
Right.
and helping the caregivers understand how to facilitate that.
Right.
It's really an art. It's quite difficult to explain.
Sure.
It involves a lot of learning about the person's history, learning about what their triggers were when they didn't have dementia. What are their triggers now they do have dementia? What was their personality like before? What's their personality like now? And how all those things sort of interject.
Yeah.
What are the things we can make better? What are the things we can't? When we can't make it better, what we need to do is we need to compensate. So it might be using equipment, or literally writing signs on the wall to say, this is where the cups and the tea bags are.
Okay.
Or the toilet is this way.
Okay.
Especially if they have a tendency to go in a particular corner of the room
Oh,
because they just
no.
can't find
Yes.
the toilet.
Sure, sure,
things
sure.
like that do happen, and it could be as simple as a sign. So the occupational therapist tends to be much more involved in that side of things. In terms of the reconditioning, exercise part, dealing with muscle imbalances, that would be the physio.
Okay.
And then a dietitian plays a big role. So we're looking at, are there issues with eating too much, not eating enough, eating a lot of sugar. Lots of them tend to get a sweet tooth. And then also the speech therapist, because if their dementia is affecting their ability. Oh.
Hey, what is?
Before Buangkok East.
Hey,
All right, sorry, we'll go back to that. Oh, right, okay, cool, no worries.
Yeah.
Let's go back to
So
it.
if this person's dementia is affecting their ability to speak, receive information, express information, read, or swallow, they're starting to choke more, or even if they're already on a feeding tube, the NGT tube that goes through the nose, that's when the speech therapist will be involved. So you can see it really takes a whole team
It does.
to support someone with dementia.
Yeah.
Because what you're doing is you're supporting the brain, and the brain does everything that we do. Yeah.
And also, I feel like, because when you're dealing with someone who has dementia, it's like dealing with two individuals, the before and the after, right? And I think like with a whole team of therapists coming in, they can have that overview, right? I think there's a lot of things that if I were the caregiver, I would miss.
Yes.
Or I would think, I just don't want them to do it because it might be dangerous. It might, they might
Yeah.
get hurt. They can't do it anymore.
You protect
not
them too much.
realizing
Yeah.
that this is actually causing them more harm.
Yeah, and it's a balance. It's a delicate balance, and that's why having a rehab therapist who's seen lots of these cases like this before is able to sort of help take appropriate risks to see how much can we do safely. And sometimes we'll take a risk and be like, do you know what? I'm not going to teach the caregiver that, because I think that is a bit too risky. Even I felt a little bit, unsure about that.
Right.
So then but then those more risky things, I would, as at Lifeweavers, we would tend to do those more during your therapy sessions, because nothing's solved in one or two sessions, especially with dementia.
Of course.
We can tend to take on those more risky things and work towards a better outcome.
Right.
We've had some amazing outcomes working in this way with people with dementia. Yeah, some really amazing outcomes, which
Could
we
you
could
share
then
a little about that?
Yeah, so there was one lady who basically became very withdrawn, locking herself in her bedroom, didn't want to come out, didn't want to do anything.
Because she was really confused with what was happening
Yes,
to her?
not cleaning, not wanting to eat, having aggressive outbursts at family.
So was she referred to you by the doctor, or was it like
By her family member.
Okay.
Yeah, it was a self-referral.
Okay.
And basically the first 3 to 4 months, so this was a longer journey, was spent really rapport building, even to the point where I was sometimes sat outside her room on the other side of the door reading the paper together.
Really?
But over the 4 months, what we were able to do is we would find activities that basically gradually brought her out of the bedroom,
That's
down the
amazing.
stairs into the living room. Then we worked on bringing her routine to come down to the living room 3 times a day, so we can look
Oh.
at breakfast, lunch and dinner.
Okay.
Then she started sharing things about her past, a recipe book that her mother had made. Now, she wasn't into cooking at all when
Okay,
she was
okay.
younger, but she started to show an interest.
Okay.
Great, let's do it. Let's stand in the kitchen. Let's carry baking trays around, because this is great exercise, and it
Right,
links her
right.
back to her past, helps her feel dignified, all of those things.
Okay.
And eventually, the main goal was actually to get her to a centre so she could go out the house 3 times a week
Yep.
and give the maid a break.
That's
so it
also
took about a year or
important,
so,
yeah.
because for her we were starting at a much more severe level.
Yep, yep,
but
yep.
after that, she went to this activity centre where they do karaoke. She joins
Yeah,
in
yeah.
with other people. She has socialisation. All of that,
Wow.
we were able to, and it was slow. We start in the living room, and then we try and find activities that get her into the garden, and then we find activities that get her towards the gate. Find activities that get her. So it's all about showing her through positive experiences that she can be,
That she can
comfortable
handle,
in these
handle
environments.
these,
And then helping the caregiver understand that if she has a sudden moment of what we might describe as challenging behaviour, or she suddenly gets angry, what to do and manage it to minimise that stress response.
Right,
Because
right,
a stress
right, right.
response for a person with dementia, I mean, I can't say this clinically for sure in terms of the studies, but I'm 90% sure it's pretty much the same as anybody else. Your cortisol increases, you start to go in fight or flight mode.
Yes.
But
yes,
for
okay.
many of us, we can rationalise that, I'm safe now, I'm okay, or that person's just really irritated me and I'm going to walk away and take a deep breath. But somebody with dementia, that system might have been triggered,
Right.
and then they're reacting to it, fight or flight.
Right,
Often
right,
it's,
right, right.
it could be either, actually,
Yeah.
depending on their history.
Yeah.
So there are lots, I say lots, there are instances of elderly people in Singapore who their memory was from the Japanese occupation. So their fight or flight response would be flight,
Right.
because they did a lot of
Yeah,
running
yeah,
before.
yeah.
For some people it's fight, and then helping the caregiver understand they're in fight or flight now. Fighting them or chasing them is going to just make it worse.
Yeah.
What are the strategies we can use to make that better?
Yeah.
I see.
Yeah.
That's
Absolutely
amazing.
crazy. Absolutely.
We are going to jump back on air to carry on this discussion, but thank you so much for sharing that. That is an eye opener. Let's head back on air.
M91.3. Turning back the clock and churning out the hits.
Awesome stuff. Bad Company. What a great song. It is 8:43. So we spoke about what you did with this lady in her home.
Yeah.
Is there therapy that happens, say, at Lifeweavers itself? What does that sort of therapy look like?
So, we would do it. We will provide the therapy in the person's home, most cases, if
Okay.
it is dementia, because
Okay.
the first thing we want is that familiarity
Right.
and to see how they're operating at home. Because your home, especially for people with dementia, but really most of us, is your daily gym.
It is.
Yeah. So you want to really look at how you're maximising routine.
Yeah.
Because if they go from basically sitting on a chair all the time and
Yep.
sitting on the mobile commode all the time for showering to walking to the bathroom, standing to have a shower, doing some baking and standing, you're getting all that standing involved without needing to hit the gym or do or even put your
Right.
exercise pants on. You can do it all in your pajamas or just
Yeah.
doing your normal day to day. So we'd be really looking at maximising things at home and looking at how people function at home with their caregivers. It's a very dynamic relationship, and it's something that is very, very, you can't be effective to the same level if you're doing this in an institution, basically, like
Right,
if you're
right.
doing it in a clinic
Right.
or a hospital, because
Right.
the environment plays such a crucial part in a person's ability
is
to
true.
function.
That is
You know, so
true.
one of a lovely therapists that we were chatting to about retraining people in kitchen skills in a hospital, she says, well, all you're really doing is teaching a person how to use a kitchen in a hospital. But what we really need to be doing is helping people use their kitchen at home. You know?
So
Yeah.
true.
So even though we live in a lot of us live in HDBs or condos, and the layouts tend to be similar, they are not the same.
That's
You
true.
know, and
That's
so
true.
so we will be seeing the people at home first and foremost, but the goal will always be to get them out. So to get them out to A centre, especially of socialisation, is going to be a really important part of their plan. Getting them involved in groups, even getting them involved in social circles. There's a lot of actually schemes and groups that are ongoing. Facebook is a great resource to find those things as well. So really sort of looking at how we can pull the resources together, going to the library, going to classes, even getting involved with sort of like schools or day centres where people can come and share their stories from the past. This is one of my favourite things about working with dementia clients is the stories. I love stories. I'm a storyteller. And just hearing this rich history, especially for the much more older generation in Singapore. Like the stories are amazing. I mean, I should have written them all down as I was hearing them. But so really anywhere, rehab anywhere, which is one of our initiatives at Lifeweavers as well.
Is there a difference in treating, say, mild dementia with severe dementia?
Yes.
Do you treat it
definitely. So it would depend on... Okay, actually, I did have a really lovely book. Let me just pop over to my handbag.
Sure. So we just want to clarify, okay, what we hold in our hands, you would see it on our Facebook Live, is a brochure that leads you to download the full guide. I wish I knew how to talk to your doctor about rehab therapy.
So you need to...
So this is a brochure. It's not the actual guide. There's a QR code at the back, tells you about Lifeweavers Therapy. And from there, you can download this complete free guide that has, touches on various topics that I guarantee you will wish you knew. So now is your chance to know. Okay.
Okay. Mild dementia, severe dementia. You said there was a book.
Yes. So what we use is this. They call it the PAL, and what it is it's an assessment that helps us categorize people basically into 4 categories.
Okay.
So we do this all through function rather than sort of looking at a clinical severity as such, because clinical only matters on paper or in a research article that's looking at the clinical side. I mean, people can have severe dementia and be functioning quite well, and people can have mild dementia and really be struggling. So from a functional perspective, we have 4 levels, which is planned activity level, which is basically where someone's pretty much independent, but they would struggle with problem solving. So if they stumbled across an issue, maybe out in the shops or even at home, they might struggle to solve that problem themselves. Okay. So then we've got exploratory activity level. So this is where somebody is able to do routine things in a familiar environment, but they're going to need more support for less routine things or if they're outside. So all this is really great information for caregivers. Then we have a sensory activity level. So this is where the person, their dementia is such that they're not so concerned about what the activity is going to achieve. It's more just about the engagement in the activity and how it feels to them on a sensory level. So does it feel good? Is it soothing? Is it overstimulating? And then the final one is what we call the reflex activity level. And that's really where somebody's they've described it here as he or she is living in a subliminal or semi-subconscious state. So they're basically just their interaction with the world and with others is much more just a reflex kind of thing. So what we would do is look at it in this way and then make sure that we can provide activities that meet that need, basically. So if somebody's at more sensory level, we'll be looking at more the sense, people have seen like sensory rooms and how we can incorporate many more sensory things to help them engage in their daily activities. So it might be things like having a really, nice smelly lavender shower gel, for example, to support showering and things like that. Or if they're when they're going to bed, having more like lights and music and sound and things like that, and experience. And for some people, sound's going to be the worst, and for some people, sound's going to be the best. So it's that sort of trial and error. But what these 4 levels do is they help give us a direction on where to start and where to build and how to make that into a personalised therapy plan for the person. So there's a big difference, and people will go through the stages as well. And so that's where we will be helping preempt people and prepare people, what might be to come and things that they can get ready or get thinking about.
I mean, it is a very complex issue, right? And the situation is, in a way, dynamic because it changes, right? As time moves on for the patient, for the caregiver and everything, So I think this is a great place to start, that we're having this discussion, that, hopefully we've opened everyone's, eyes, ears towards the idea that, hey, go and see a rehab therapist if you feel that, a loved one of yours could be exhibiting the possible signs of dementia.
Absolutely. If you want to check out Lifeweavers, at Lifeweavers on IG or lifeweavers.org, that's their web. Check them out there. Make sure you get the guide as well. It's going to help you a lot. Liz, thank you again for coming in. It's always wonderful.
Always welcome. Thanks for having me back.